Good evening, everyone, and welcome to our webinar on the emerging strategies in tackling antimicrobial resistance in urology. Now, I'm very grateful for everyone who has joined and all our panel here, expert panel, who's going to take us through a journey on what's new and what can we do. There's no need for me to explain that antimicrobial resistance is on the rise. We all know about this. We all live this day to day, see when we're caring for our patients. So we will start off by still the best way of dealing with the issue, whereby it's stewardship, antibiotic stewardship, using the antibiotics, not just carefully, but in a smart way. So who else is best placed than Professor Tommaso Kai to tell us how to use antibiotics in a smart way? Following that, you need to be obviously updated on the knowledge. What's the newest guideline recommendations and what are the guidelines indicating? Obviously, not everything is in the guidelines, and you have to understand that evidence is constantly emerging. So we're privileged to have Professor Gernot Bonkat, the chair of the EAU section of infections guideline, who's going to give us an update on the topic. And then it comes into the story of the impact of antimicrobial resistance. As it starts and it goes on from maybe what you would call a simple infection or a catheter infection, you eventually start seeing patients with sepsis. Our own research has indicated that if you put the first two together, stewardship and follow guidelines, and you have a local data, you're in a very privileged position to use your antibiotics in a very accurate way in treating urosepsis, a severe lethal condition. But there's more to that. There are things that are emerging now. And one of our best experts in this field, Professor Florian Wagenlehner, will take us through that. So we have a very unique panel today, and I'm very privileged to be chairing this alongside our very senior member of our team, Professor Truls Erik Bjerklund Johansen. So, and he's going to take us through the Q&A session at the end. Now, having said all of this, just before we start, I would like to extend our thanks to the EAU and European School of Urology, who have provided us this platform to deliver these messages and share this knowledge with yourselves. I would just like to highlight that this is the first of the series whereby our mission as the European section of infections in urology has been now highlighted as antimicrobial resistance. So you'll be hearing more and more about this topic from ourselves at the EAU conferences and further publications and further webinars on this platform. So without any further ado, without much more introduction, I'll hand over to our first speaker, Professor Tommaso Kai, to take us through antibiotic stewardship. Thank you very much.
Thank you, Zafar. Good evening, everybody. Many thanks for inviting me to speak about a very interesting topic in everyday urological practice. Many thanks for this kind invitation also to Zafar and to Professor Johansen and to EAU and to European School of Urology. So I think that this is the time to make a point in the meaning and importance of antibiotic stewardship in urology. This is my disclosure statement, and this is the outline of my presentation. Today, I would like to start from the background. I would like to highlight what's happened in the management of urinary tract infection. What's news, what's the mistake, and what's the actual situation. Moreover, I would like to define the antimicrobial stewardship, and in particular, I would like to discuss with you some areas of interest in urological practice in which we can improve our microbiological stewardship. Moreover, I would like to give you some take-home message and discuss with you some future perspective for our improvement of antimicrobial stewardship in urological setting. Starting from the background. From about 5 years, I generally start my presentation about antibiotic treatment of urinary tract infection or about antimicrobial stewardship with this question. But I think that this question is very actual today. The question is, why are we still talking about the antibiotic treatment of urinary tract infection about 80 and more years after the discovery of penicillin? This is a very actual question, and we need to take into account in everyday clinical practice. The reason is that this is the actual situation. As you will know, and as Professor Zaffer highlighted before, antibiotic resistance is one of the biggest public health challenges for clinicians and healthcare system. Moreover, we have estimated that about 300,000 people die in Europe in the 25 years from multi-drug resistant bacteria and from pan-resistant bacteria, more than the COVID pandemic. This is very important to take into account because now we are able to change the natural history of the antimicrobial resistance, but this is the time to change also our point of view and our clinical practice. As we all know, antibiotics are the most commonly prescribed drug, but more about half of them are not needed or not optimally prescribed. Fluoroquinolone, for example, from antibiotic prophylaxis in ambulatory cystoscopy, or some other setting in which the treatment is not indicated, but we continue to prescribe antibiotic. And we have a lot of cost, direct and indirect cost, about the non-optimal prescription of antibiotic. This is the situation. This is very dramatic. The numbers are dramatic. And as you all know, the inappropriate use of antibiotic was the reason of the rapid emergency of resistance. In this picture, very nice picture, you can find the year of antibiotic development, the year of antibiotic discovery, and on the bottom of the feature you can see the year of the first resistant observation. For some class of antibiotic, the year of antibiotic development and discovery is very similar to the year of the first resistance observation. This is important. This is important because now we have not any drug to use in everyday clinical practice. This is the European situation. Klebsiella pneumoniae, for example, that is very implicated in urinary tract infection, as very shows a lot of resistance against fluoroquinolone, of course, against cephalosporin, third generation of cephalosporin, and we have a very pandemic emergency of KPC, Klebsiella pneumoniae, resistant to carbapenemicin, especially in Italy and Greek. Moreover, Acinetobacter, for example, shows a high prevalence of resistance to fluoroquinolone, aminoglucoside, cephalosporin, and carbapenems. And as you will know, the Acinetobacter is frequently implicated in the pathogenesis of complicated urinary tract infection. This is the time to change our point of view. This is the time to change our clinical practice. A new approach is urgently required, and probably they improve our antimicrobial stewardship in urology, in all urological setting, is the new approach to take into account. Moving to the definition of antimicrobial stewardship, we can define the antimicrobial stewardship as a coherent set of action which promote using antimicrobial responsibly. This is a very interesting definition, but it's not enough. The definition is not enough. Recently, the CDC improved the definition of antibiotic and antimicrobial stewardship, highlighting to measure and improve how antibiotics are prescribed by clinicians and used by patients. This is very important because in antimicrobial stewardship, we have two actors, the clinicians, of course, but the patients too, because we need to count on to patients too in order to improve the antibiotic stewardship. The CDC highlight also that a correct approach to infection and the correct use of antibiotic is able to efficaciously treat infection, of course, but also protect patients from adverse effect and from resistance and combat antibiotic resistance. In other words, antimicrobial stewardship and the adherence to antimicrobial stewardship program is able to improve antibiotic efficacy, of course, reduce antibiotic resistance, but also is able to protect patients and protect environment. The environment is very important in order to control the antimicrobial resistance also in humans. And antimicrobial stewardship is able also to protect the environment. Please keep in mind that this picture, because of the antimicrobial stewardship, as we discussed before, we have two actors and we have two pillars in if we can improve our antimicrobial stewardship. We need to count on patients, of course, and to clinicians. But in urological setting, how I can improve my antimicrobial stewardship adherence? The international guideline that Professor Bonkat we will discuss after in depth suggests to perform a new approach. We need to improve our adherence to the guideline recommendation, of course, but also we need to take into account all risk factors related to the patients and related to bacteria. Moreover, we need to choose the best antibiotic that is able to treat the infection. And finally, but it's very important, several times we need to prefer an antibiotic sparing approach to urinary tract infection. In everyday clinical practice, we need also to consider a modern approach to the management of urinary tract infection. As in oncology, as well in oncology setting, also in urological, in urinary tract infection management, we need to perform a patient counseling because we need to discuss with the patients about the risk factors and preventive measures. But we need also to perform a patient's engagement because, as we'll know, if the patient is engaged, the compliance to the treatment is very high and the adherence to our treatment is high. Moreover, we need to perform an accurate patient education. We need to educate the patient to avoid self-medication, for example, or unnecessary diagnostic examination, for example, urinary culture without any symptoms. Every day in clinical practice, we have a lot of patients that have urinary culture, that make a urinary culture without any symptoms. So, but in everyday clinical practice, what are the areas of interest in urological clinical practice in which we can act in order to improve our antibiotic stewardship? The CDC highlight several core elements of antibiotic stewardship in several settings in which we can improve our antibiotic stewardship. But and the CDC highlight several important components that we can that we can adherence in order to improve the antimicrobial stewardship. The CDC suggests to perform a regular training of the staff in the hospital, of course, but not also in the hospital, also in the outpatient management, in a GP, for example, to improve the use of antimicrobial agents accurately prescription. Moreover, the CDC suggested to improve our adherence to local, national, or international guideline. Moreover, they suggest to perform a regular visit and consultation with infectious disease physicians and perform a regular audit in order to revise our local resistance, discuss with a microbiologist, and discuss with infectious disease in order to improve our adherence to the antimicrobial stewardship, because the local resistance rate are very different. Especially in Italy, we have a very difference among the regions in terms of resistance. For example, in the north of Italy, in Trento, in my city, we have a resistance against cotrimoxazole among E. coli about 10%. In Tuscany, or in the south region of the Italy, the resistance among E. coli to cotrimoxazole is very high, about 25–30%. And this is very important to take into account. In urology, we have two settings in which we can act in order to improve the antibiotic stewardship: the outpatients and the inpatients. Starting from the outpatients, what are the core elements of the outpatient antibiotic stewardship program? We have some area of interest in which we can act every day in our clinical practice. First of all, the treatment of uncomplicated urinary tract infection. This is very important to perform the best antibiotic choice and choose the best antibiotic, consider the local resistance, the international guideline, and so and so. Moreover, the management of asymptomatic bacteriuria. This is very important to stick to the international guideline in order to know if I have to treat or not to treat the asymptomatic bacteriuria. Moreover, the prophylaxis and the management of a recurrent urinary tract infection. In this kind of patient, we need to perform an antimicrobial sparing approach in order to reduce resistance, in order to improve the compliance of the patient. Moreover, also in outpatients, as well in inpatients, we need to consider a correct use of urinary catheter. Avoid the overuse of catheter. About 30% of patients in inpatients have an unnecessary catheter. And this is very high risk of catheter-associated urinary tract infection. How can choose the best antibiotic to use? Of course, I need to consider the spectrum of coverage. I know that in urinary tract infection, where uropathogens are the most common isolated strains, and I need to use an antibiotic that is able to act against uropathogen, of course. But as we discussed before, I need to consider the partner of local resistance. This is very important. And of course, I consider the allergy to the patients and so and so. Another important aspect, please treat bacterial infection and no treat colonization. Asymptomatic bacteriuria is a very example of this practice. And moreover, and we need to avoid to treat Foley catheter colonization with antibiotic. Moreover, we need to consider that presence of white blood cells in the urine is not always indicative of infection. And moreover, the fever could be maybe due to other reasons, also in patients with a urinary catheter. Please keep in mind this aspect. Here, I would like to remember you our study about the symptomatic bacteriuria management in a woman affected by recurrent urinary tract infection. As you will know, the treatment of asymptomatic bacteriuria in women with recurrent UTI is associated with a higher risk of new symptomatic episode and a high risk to antibiotic resistant strains. Moreover, in class 3 CPPS syndrome, is not needed to use antibiotic, or moreover, is not needed to use antibiotic in order to decrease the PSA. But it is very important, it's a very common practice also in my department. Moreover, we can treat the symptoms and the patient, and not we need to treat the imaging suggestive for pyelonephritis, for example. Moving to the sparing antibiotic sparing approach to recurrent urinary tract infection, I would like also to show you our meta-analysis about the use of a compound containing xyloglucan and other phytotherapy compounds that is able to reduce the symptomatic episode in women affected by recurrent urinary tract infection. And this is demonstrated by a meta-analysis. Moving to the inpatients. In inpatients, we need to consider other aspects in order to improve the antimicrobial stewardship. In inpatient, we need to consider the antimicrobial prophylaxis. Also, in urology, neurological section, we need to choose the best antibiotic that is able to achieve as antimicrobial prophylaxis in our patients. And we need also to stick to the international guideline in order to avoid the unnecessary use of antibiotic in some urological procedure. The management of complicated urinary tract infection and sepsis is another area of interest in which we can improve our antimicrobial stewardship. Moreover, also in inpatients, we need to consider the correct use of a urinary catheter and pilostomy, nephrostomy, and other urological device. And moreover, in inpatients, we need to create the infection control team, because it is very important in order to educate the physicians, in order to educate all sanitary person, and in order to establish our hospital program in order to improve antimicrobial stewardship. Here, I would like to remember you in our paper published a survey years ago in European Urology, in which we demonstrated that the antibiotic prophylaxis performed in line with European Association of Urology guideline is able to reduce the use of antibiotic, the cost of antibiotic, and the resistance. And this is very important to consider the international guideline, the European Association of Urology guideline, in order to choose the antibiotic to use for antimicrobial prophylaxis in urological setting. In other setting, other surgical setting, has been demonstrated that the adherence of international guideline is able to reduce the cost of antimicrobial prophylaxis. Moreover, in complicated urinary tract infection, we need to consider every 2 days the reevaluation of the patient. We need to limit the day of the intravenous therapy, and we need to switch to oral treatment as soon as possible. We need also to consider the local resistance, and we need to guide the antibiotic on the results of urinary culture in the case of complicated urinary tract infection. Other procedure for improving our antimicrobial stewardship adherence is important. Not only antibiotic, but other procedure are important, such as the use of preventing infection as a good hand hygiene, infection control practice, and remove catheter as soon as possible, or avoid to place catheter when not needed. Finally, I would like to give you some conclusion in order to consider the role of antimicrobial stewardship in urology and discuss with you some future perspective. I would like to conclude highlighting that in the era of antimicrobial resistance and multi-drug resistant bacteria, antimicrobial stewardship is a very important procedure to consider in urological setting. And I think that all urologists are called to establish and to continue to improve the antimicrobial stewardship program and strategy from the diagnosis to the treatment. Moreover, we need to consider also all aspects related to the pharmacokinetics and pharmacologic before prescribe antibiotic. But it's very important to stick to the European Association of Urology guideline in order to avoid the mistake that in several cases are very dangerous. Well, in conclusion, look to the future. As you all know, complicated urinary tract infection management is based on the use of antibiotic, supportive therapy, urinary system drainage or reception, so and so. This is why work in progress, because from 1 year, we are looking for if the preventive management of and the education to the staff and clinicians is able to reduce the prevalence of complicated urinary tract infection and improve the outcome. Sorry for this delay, and thank you for your attention.
Thank you very much, Tommaso. Very, very detailed explanation. And what's quite impressive is that you were already answering questions that were popping up in the Q&A chat. Without any delay, let's move on to the next part of our webinar, which is Professor Gernot Bonkat, who will talk about the guideline recommendations. You can see your slides. Thank you.
My task today is to speak about the topic EU guidelines recommendations for tackling antimicrobial resistance. These are my conflict of interests. I still live in Basel, Switzerland. Basel is considered to be the cultural capital of Switzerland. We have a lot of museums, and it's a nice and beautiful city. Since 2015, I have the honor to chair the guidelines on urological infection from the EU. These guidelines are endorsed by more than 74 national societies and scientific organizations, including all 27 member states of the European Union. In 2024, this year, it's time to retire. And I would like to thank everyone who has joined the work, who has contributed to the guidelines, especially to my colleagues from the panel and the associates. And if we step back, we can say that we have done a good job. So we are number 2. It's meaning that we have earned the silver medal regarding the downloading capacities of all guidelines. In the sense that the king is dead, long live the king or the queen. The position of the guideline chair was announced recently, and I would like to encourage interested colleagues from all over the world to apply for this interesting position. Coming to the topic of antimicrobial resistance, then we know that antibiotics have revolutionized medicine. But we know as well that we have problems coming with the topic of antimicrobial resistance. And we know that the main drivers of both its development and spread are man-made. And one of the huge topics is the misuse and overuse of antimicrobial in humans, because this is where we as urologists can have some influence. Shortly to the mechanisms of resistance, we know that we have a few, especially in gram-negative bacteria. One is the loss of porins and the increased expression of efflux pumps, it meaning that the antibiotics are just pumped out of the bacterial cells. We have target site mutations, and we have the beta-lactamases. With the beta-lactamases, you can see that we have an evolvement. We have started with beta-lactamases, and we are currently ending up with colistin resistance. This is meaning that we are straight on our highway to hell or stairway to doom, however you would like to call it. The problem is that we have as well problems that bacteria can share these resistance genes by a horizontal gene transfer. And this makes the story complicated. As well, that we have the problem that these resistance genes are spread all over the world. And there's evidence by increasing research that the human movement significantly facilitates the global dissemination of resistant bacteria and antimicrobial resistant genes. Notably, this is more frequent in high-income countries, often become of AMR from middle or low-income nations, especially from Asia. And antimicrobial resistance is not a new problem. It's well recognized. If you take a look at the headquarters of the United Nations, already in 2015, there was emphasized as a necessity for a coordinated action plan to address antimicrobial resistance in human, animal, and agriculture sectors, known as the One Health approach. And this marked the fourth instance of a health topic being discussed at the Assembly. And all 194 member states pledged to combat antimicrobial resistance by adopting national action plans within 2 years, aligning with 5 objectives outlined by the WHO. And this is the Global Action Plan on Antimicrobial Resistance. And the fourth objective of this plan is to optimize the use of antimicrobial medicines in humans' health through the development of national and hospital treatment guidelines. But it was not only the WHO and the United Nations, as well in Europe. Recently, the European Council has launched a project, and there was a concerted effort to address the growing public health issue, antimicrobial resistance. And there's a council recommendation on stepping up European Union actions to combat the problem, as well in a One Health approach. And this was adopted in June 23. And this included 5 targets to be achieved by 2030, building on a 2019 baseline. And these are the recommended targets reached by 2030. And this is an update. What you can see here is that it's already in 22, it was updated, baseline 2019. Okay, we have seen that there's a reduction of the total consumption of antibiotic in humans, but we have not reached the second and third point. As well, what is really concerning is that point number 5, that this was aimed to reduce the incidence of bloodstream infection with carbapenem-resistant Klebsiella pneumoniae, and we have not a reduction, but we have almost 50% increase. If you take a little bit a deeper look, what is recommended in the council, then you find often the word guidelines. Guidelines, appropriate guidelines should develop guidelines, international guidelines should be taken into account, etc., etc. So who or everyone is advocating for guidelines. But then it's a question, are we a little bit too late? Because Pandora's box is already open and who will close it? We have heard about the mortality projection of antimicrobial resistance. We have heard that in 2050, a lot of people will die because of antimicrobial resistance. But what is the situation today? What is the situation worldwide? And we already know that in the year 2019, almost 5 million people deaths were associated with bacterial antimicrobial resistance. And we took a deeper look in the bacteria who are responsible, then we find our bacteria we are dealing with, E. coli, Klebsiella, and so on. What is the situation in Europe? In Europe, it's a similar situation. So we have resistance bacteria infect around 800,000 people per year. We have 100 people who are dying every day in Europe in 2020 because of antimicrobial resistance. And we have a huge damage of our economy system because we are losing trillions of euros each year. It's comparable to that money that have been spent because of the COVID-19 pandemic. So we have a problem. And what can we do? what can our guidelines do, what can EU guidelines or recommendation do for tackling antimicrobial resistance. So first of all, I have to ask, have you done your homework? Have you read our guidelines in detail? And if you say yes, then perhaps you are a little bit flunkering. If you're lying, it's not a problem, because I've read, if you ask a nice person and you have a 10-minute conversation, then the person will lie 2 to 3 times to you. But this is very important. We have to read. If we are not read, then we can not improve our knowledge. So there are antibiotic stewardship, and there are so-called 6 Ds for antimicrobial stewardship. I will focus only on 5, because I would like to speak about the outpatient antibiotic stewardship for urinary tract infections. This is a study published by Goebel et al. A few years ago, and there's written that the antibiotic stewardship for outpatient management of urinary tract infection can be framed by the 5 Ds, and the 5 Ds are diagnosis, the drug, the dose, the duration, and the de-escalation. And I would like to show you that our recommendation, or what we have written in our guidelines, is matching what is recommended by these antibiotic stewardship means. So first, we take a look about the diagnosis. And we have heard from my friend Tommaso already said it's very important that we differentiate between urinary tract infection and asymptomatic bacteria. But we have to differentiate between urinary tract infection and sexually transmitted diseases as well. And what is working for it? Of course, careful history should be taken, and we have to take a careful history as well to elicit symptoms of sexually transmitted diseases. As we've heard, it's of utmost importance to differentiate between asymptomatic bacteria and infection. So we are dealing in our guidelines with a huge population of patients with asymptomatic bacteria, and we give recommendations for every study population. And so you can see that we are recommending not to treat asymptomatic bacteria for the following conditions. I just would like to say a few: women without risk factors, postmenopausal women, elderly people which are in institutions, patients with renal transplants, and so on. And we are saying as well that we should not screen or treat asymptomatic bacteria in general. So if you just follow these 2 tables, you avoid a lot of unnecessary prescription of antibiotics. Then we have same as well the diagnosis for uncomplicated cystitis. We are speaking about the need to take urine cultures. We have focused as well the difference between women with or without vaginal discharge, where we can divide between urinary tract infection and sexually transmitted diseases. And if we go wider, if you continue with the right drug, right dose, and right duration, then I come to one of my favorite tables, because this table is offering everything you need. So we are offering fosfomycin and nitrofurantoin for the first line to treat urinary tract infections. We say no to aminopenicillins or fluoroquinolones, no to broad-spectrum antibiotics. Why? Because of the negative ecological effects, high resistance rates, selections of ESBLs, and the side effects. The daily dose and duration of therapy is mentioned as well in our guidelines. We have discussed the topic in detail with the fluoroquinolones, and we can say as well that these fluoroquinolones should not be used, and we are speaking about that they should not be used since almost 5 years. And we have a few categories where the indication should be maintained, and this could be read in detail in our guidelines as well. De-escalation of antibiotics is meaning at least that you, for example, if you have taken a urine culture and you reduce the culture and you see that there's no bacteria growing, then you have to reconsider your diagnosis of infection, or you can narrow your antibiotic treatment based on your culture results. So using guideline helps. This has been shown by my colleagues as well recently. And the problem with the guidelines in the context of AMR is multifocal. We have a problem because trustworthiness concerns. So variation in the methodology, conflicts of interest, and lack of transparency raise doubts about the reliability of guidelines. This is one major aspect. Then we have a few more. This is a problem, and this might cause that the guideline adherence in general is slow, not only to our guidelines, but for example, for the IDSA guidelines as well. This is taken from the internet. This is a situation in Switzerland. There we have different guidelines as well. And you can see on the right, Blasenentzündung is meaning urinary tract infection or cystitis. And you can see that there are still 20% of uncomplicated or cases of uncomplicated enteritis are treated with fluoroquinolones. I don't know why, but this is our main task, to bring guideline recommendation to the clinicians. Finally, I have to say that it's bad luck, but the bacteria, they have an advantage and they will keep it. This is an interesting story from New Mexico in the US. And there are so-called Carlsbad. It's a small city, and we have there the Carlsbad caverns. And these are a cavern. This was closed for at least, it's estimated, 2 million years. So no one has access to the hole. And in the water, in this cave, bacteria were found which have resistance against many antibiotics we are using today. And this is general problem that the microorganisms might be a step ahead of us because they have this big advantage of evolution. And so we can say that bacteria have seen dinosaurs come and they have seen them go, and you can guess what they will see with respect to mankind. So I would like to conclude that antimicrobial resistance is recognized worldwide as a major problem. The global governance of AMR is complex because of many different topics. We have worldwide strategies to tackle this issue, and these strategies has to be implemented. And we as urologists, we have to be very much concerned because of the wide spectrum of infectious diseases in our field. But we should not forget that we have already tools to face this emerging problem. And I can say that reading our EU guideline recommendations help tackling antimicrobial resistance, but you have to read them and we have to use them. Thank you very much.
Thank you very much, Gernot. Thank you for a very colorful presentation in summarizing such a difficult topic. And for the next challenging topic, I will invite Professor Florian Wagenlehner from Germany to go through urosepsis antibiotic selection, please. Thank you, Florian.
Thank you very much for introducing Savar. Good afternoon, good evening from my side also. My topic is now to talk about the best antibiotic selection for the most severe infections we have, urosepsis. There is no potential conflict of interest from my side to this report. And what I would like to start with is to introducing the so-called Tarragona strategy. The strategy is 5 recommendations how to choose the best antibiotic in severe septic patients. That was introduced 2014 in a town called Tarragona in Spain. And here you see the recommendations. Look at your patient, listen to your hospital, hit hard, get to the point, and focus, focus, focus. So what is meant by this different recommendations? Look at your patient. There you mean that it is extremely important in the initiation of the management of septic patients to know the focus, which kind of sepsis we have in front, because this is the bacterial spectrum of different septic focus. And as you see here, the urinary tract has a totally bacterial different spectrum that, for example, lung infections or CNS infections or other infections. So therefore, it is important to know what kind of septic focus we have in front of you. And then this is a study from Safa Tandoğdu, who looked into the bacterial spectrum of uroseptic patients, 400 uroseptic patients that were captured in the global prevalence study of infection urology, a global study from the European section of in urology, the ECU. And here we see we have mainly gram-negative pathogens, but not only, we also have gram-positive such as Enterococcus. And amongst the gram-negatives, we also have E. coli, but also very resistant ones such as Klebsiella or Pseudomonas aeruginosa. So this is the bacterial spectrum you have to keep in mind and in front of you. But it is wise and prudent to tailor down the bacterial spectrum in certain patient situations. For example, as in this patient that has bladder stones, kidney stones due to multiple catheters, indwelling catheters, and of course you decompress the kidney. But for antimicrobial treatment, you have to consider also Pseudomonas aeruginosa in patients that have catheters, long-term indwelling catheters, and therefore Pseudomonas active agent would be warranted as an empirical treatment. Another example is here. For example, this patient has emphysematous pyelonephritis, and this is a typical pathogen that is causing this is usually Klebsiella pneumonia, which is also for its inherently resistant in some regions of the world. So in those patients, I would recommend to choose an antibiotic that covers at least Klebsiella pneumonia. So, and these are patient examples where you can start tailoring down your broad bacterial spectrum. The second recommendation is listen to your hospital. Listen to the environment of the patient. What is meant by this? If we look, and this is also data from the global prevalence of infection urology study on uroseptic patients in urology, if we look on a worldwide basis on the antibiotic resistance in urosepsis, then we see high level resistance rates apart from carbapenems with all other antibiotics, routine other antibiotics we are currently given, if we look into monoantibiotic treatments. Some recommendations and guidelines include that antibiotics should be combined in septic patients. But even if we combine different antibiotics, we don't get below 20% resistance rates apart from giving carbapenems, for example, with antibiotic combinations such as piperacillin and tazobactam and gentamicin. Therefore, the global antibiotic resistance does not bring us too much further if we want to select the best antibiotic option for our individual patient in our region. And therefore, we need to have individual resistance surveillance within our hospital, and the best would be to have antibiotic and the best would be to have molecular analysis. This is, for example, a molecular analysis on different strains of bacteria we have in our department with regards to the different individual beta-lactamases. And you see here the most frequent beta-lactamase we have is TEM1 or CTXM, ESBL, and we know that CTXM, ESBL, for example, is covered by tazobactam. So, for example, in patients where we have fear of resistances in our region, in 2016, piperacillin and tazobactam would be, for example, an antibiotic that would cover even the resistant pathogens. However, this is not anymore true also in Germany, because since 2 years, we note an increase of carbapenemases in Klebsiella pneumonia and other enterobacteria apart from Klebsiella pneumonia. And this is linked to patients that had an exposure in Ukraine, where there is a war since 2 years that has been started by Russia on Ukraine, and due to wound infections, indwelling catheters, loss of control of antimicrobial policies, high-level resistant organisms had spread over the country and are now spilling over to neighboring countries. And for example, this is a patient we have seen with progressed cervical cancer because health care is on the floor in Ukraine with a bilateral congestion of the kidney, and the urine seen in this patient is, for example, a high-level resistant Klebsiella pneumonia with NDM carbapenemase, an OXA48 carbapenemase, and an ESBL enzyme, all in one bacterial clone. And the most problematic thing about this is the resistance, as you see here, because this bacterium is already resistant to the last resort novel antibiotics such as ceftolozane, tazobactam, ceftazidime, avibactam, cefiderocol, imipenem, relebactam, or meropenem, vaborbactam. So as has been said in the previous talks, the resistant genes are around, and if you lose control about antibiotic policies, we will have one or the other day high-level resistant organisms. The third recommendation is hit hard, and you could add and early, because this is a study by Kumar a couple of years ago in septic shock patients, and he could show that a delay of the adequate antimicrobial of each half an hour increases mortality because the adequate antibiotic has not been given in the right time. So the adequate antibiotic needs to be given as soon as possible. And there we are with our guidelines that have been introduced by Gernot Bonkat in the previous talk. These are antimicrobials that are recommended for treatment of severe urinary tract infections by the EAU guidelines. And I have given you some indications where you can select for one or the other. What is still not completely clear is if combination antibiotic therapy would be advantageous, and there are some evidences, however, not from randomized study, that combination antibiotic therapy could perhaps increase survival, but high-level evidence is still lacking, and therefore in some guidelines combination antibiotics are recommended, but it's not necessarily in all the guidelines. Get to the point deals with the pharmacokinetics and the pharmacodynamics of antibiotics. How can I improve the efficacy of antibiotic by improving the dosage? And here you need to know that within the antibiotics we have antibiotic substances that follow peak concentration association, and others such as all the beta-lactams that follow time association pharmacokinetics. And that means if there is an association with peak concentration, high dosages and rare dosing is recommended. This is, for example, in aminoglycosides and fluoroquinolones that usually are given once or 2 times per day, whereas in so-called time-associated antibiotics, low dosages and frequent dosing is recommended. In septic patients, sometimes continuous infusion of antibiotics is recommended to improve and optimize efficacy of the antibiotic. Because pharmacokinetics in septic patients is significantly altered compared to non-septic patients. For example, the cardiac output is increased, and that increases clearance of the antibiotic. Therefore, you have to dose higher. Only if organ dysfunction by kidney or liver dysfunction is present, perhaps the clearance is reduced, and then you can reduce the antibiotic dosage. But usually you have to increase the antibiotic dosage. The capillary leakage is increased. That increases the volume of distribution. Therefore, you have to increase antibiotic dosage. Half time is increased. Drug interactions play a role. Sometimes the protein binding in the later courses due to the reduce of plasma protein is increased, and therefore free antibiotic concentration increases. So it's a very complex situation, and the best way to overcome that is therapeutic dosing, TDM. In this randomized study by Stefan Hagel, who randomized patients with a control group, normal recommended, and those who get therapeutic drug dosing, you can see that the target attainment here measured in the percentages of patients at day 1 to day 5 who are at the right target is increased in those patients where you have therapeutic drug monitoring. That means you monitor the drug concentration in the blood at certain time points. However, this did, at least not up to now, in this study, not translate into an increased survival. So the attainment is better, but it did not translate into an increased survival. And the last recommendations is focus, focus, focus. And this means also in septic patients, de-escalation is recommended, not only because of antimicrobial stewardship, but you also reduce mortality in the ICU, in the hospital, and measured in this study up to 90 days post sepsis, probably because the collateral damage on the microbiome is reduced, and that saves lives. And that means, for example, in a patient where you can nicely control the effect of your treatment, if the procalcitonin, for example, goes down on the second and third day when you have your susceptibility results available, you can readily decrease and narrow down the antibiotic to a lower and more narrow antimicrobial spectrum. So in summary, we have in septic patients a very complex situation. We have the patient with the organ function that are highly altered compared to normal patients. We have maybe specific pathogens with bacterial resistance depending on the circumstance of these patients. And we have within the antibiotic a lot of parameters that need to be taken into account: pharmacokinetic, pharmacodynamic, protein binding, and the clearance. So as a summary, in septic patients, usually the dosage is too low, and therefore you have to give higher dosage, and that usually is recommended to give the double dosage at least at the start of the antibiotic treatment. Thank you very much.
Thank you, Florian. We have a couple of questions. One is related to intravesical administration of antibiotics from Jane Mainlink. Could you answer that, Gernot? Does intravesical administration have a role?
So intravesical instillation with antibiotics will play, as far as I can see, definitely a role, but it has been played a role in the past as well. So the installation of aminoglycosides seems to be quite helpful, at least in the reduction in the case or in the setting of recurrent urinary tract infection. But it should not be a first-line approach, but it could be some sort of last line of defense approach. And we have more and more studies coming that are in favor of such an approach. And as soon as we have the evidence that we need to have it, then we will recommend it as well. But I think this will be something that will be recommended soon.
And there is one question for Tommaso. How can we avoid giving unnecessary antibiotics in suspected chronic prostatitis? What is the key investigation?
The key investigation is the MER-STAME test, of course. This is very important because it is able to isolate the bacteria, for example, evaluate the resistant profile of bacteria, and moreover is able to evaluate if the prostatitis is inflammatory or non-inflammatory and target the therapy, not only antibiotic, but also the anti-inflammatory drugs or phytotherapy. The MER-STAME test is the answer.
I think the chairman needs the last few seconds to summarize. Thank you, Sofie.
Thank you very much. And we'll be respectful towards the time, so we'll end in the next minute. But this was absolutely amazing journey to illustrate, number one, that you can start all the way from asymptomatic bacteriuria, which we wouldn't want to eradicate, even if the bacteria you identify has features of drug resistance, which was highlighted beautifully in Tommaso's talk. Adherence to guidelines clearly improves outcomes and avoids further resistance, which again was highlighted in Gernot's talk. And that, I think, was the best talk I have ever seen in urosepsis by Florian, summarizing how we should hit hard, we should hit on time, but keeping in mind the antibiotic stewardship. And I learned a lot on that talk also, that cutting the antibiotics sooner rather than later has a beneficial effect in the right patients also. So please continue to follow us, because we'll have a further series on antimicrobial resistance and how to deal with this issue. And I wish you all a very good evening. Thanks for joining.